So my privilege to invite Dr. Rajesh Kannan for all pediatric and congenital valvular heart disease specialists interested, they can enjoy this session. So I think whatever he has to say, we'll listen from him.
Yeah, good evening all. At the outset, I would like to thank the organizers, especially Dr. Kumar, for inviting us to this wonderful meeting. So next 25 minutes or so, I'm going to discuss about the role of cardiac MRI in valvular heart disease and congenital heart disease. So first we'll discuss about the valvular heart disease. Why MR? So as already Dr. Sanjay has discussed the different pulse sequences available and its overview of clinical applications. In pertaining to the valvular heart disease, why we need an MR, where our echo can give you most of the information. The main advantage of MR is its high reproducibility and the combined objective assessment of blood flow, ventricular volume and mass, motion. Importantly, it can assess the scar and other anatomical information. Also, we can use this as an objective assessment in different therapeutic trials where you need accurate quantification and reproducibility, as well as we can use MR for decision making, whether patient needs surgery or not, in case of where there is a mismatch in your echo and the clinical findings. And if you look at the cardiac MR, using the different sequences, we can quantitatively evaluate the valves and subvalvular apparatus. What you are looking at it, using the different pulse sequences, mainly the cine sequences, where we can assess the doming of the valve or the valve thickening, leaflets thickening, bicuspid versus tricuspid aortic valve, as well as we can do a planimetry. The valve area can be assessed when you are suspecting a valvular stenosis. So all those things can be assessed in echo also. The added advantage of MR is similar to the echo. We can quantify the stenosis using the flow measurements called the phase contrast, where using the modified Bernoulli equation similar to the echo, we can calculate the pressure gradient across the valve stenosis. So in this case, if the peak velocity is 504 centimeter per second, so using the formula of 4V squared, we can calculate this as 100 millimeter of mercury. But even though these things can be assessed using the echo itself, the added advantage comes in MR. See, the MRI, you can look at not only the valvular abnormality, we can also assess what the valve pathology produces secondarily in the myocardium. For example, this very nice article, we showed that they assessed the myocardial scar in patients with severe aortic stenosis. And when they looked at the patients over a period of 1 year, if they don't intervene at this point where the myocardial scar has started, and it has progressed within 1 year, we can see that there are multiple areas of scar. Whereas in the second case, where we can see that when they immediately after seeing the scar, when they did the aortic valve replacement, then the scar didn't progress. So we can know that once the myocardial scar develops, it is an irreversible injury. So the recommendation is we have to do the aortic valve replacement in the case of severe AS before the mid-valve LGE starts developing, or when you start seeing, that is one of the indication for doing a aortic valve replacement, and we cannot now wait further because it will produce a further irreversible damage. Also, it is very important to know that not all patients with aortic stenosis having a LVH is essentially due to aortic stenosis, because a lot of patients now have associated amyloidosis is a very well-known entity, cardiac amyloidosis in the presence of aortic stenosis, and cardiac MR is one of the gold standard modality currently available to quantify or characterize the LV myocardium. So you can get the tissue characterization, and all sort of the LGE is very well can be easily picked up on a cardiac MRI using a delayed scan, as well as we can also use the myomapping sequences. So we should not miss associated cardiac amyloidosis in the presence of a aortic stenosis and the LV hypertrophy. Coming to the valvular insufficiency, so MRI is much more commonly used in valve regurgitation than the valvular stenosis, as most of the cases we can easily assess by the echo itself. When you are coming to the valve insufficiency, one is we can semi-quantitatively assess the regurgitant jet using the gradient echo sequences, but most of the time we will be using the phase contrast flow study. So how will you quantify the regurgitant volume and the regurgitant fraction? If it is a single valvular disease, we can just look at the difference between LV and the RV stroke volume. It will be applicable for both for the semilunar valve or the atrioventricular valve level. Whereas for the semilunar valve, whether it is a aortic regurgitation or a pulmonary regurgitation, just by looking at the PC, the regurgitant flow, the backward flow is equivalent to the regurgitant volume. So this is an example of a pulmonary regurgitation, where by simply doing a PC at the pulmonary artery level, just above the level of the valve, we can directly get the value of what is the forward flow and the negative flow. In this case, the regurgitant flow is about 3 liters, so which is the regurgitant volume, and we can calculate the regurgitant fraction as the regurgitant volume divided by anticreate volume into 100. So this takes only a 1 minute of scan time and 1 minute of post-processing. It's very, very simple and no other complex mathematical or calculation involved. So that is the beauty of cardiac MR. So we can directly quantify, and this is the most widely used technique when patients with post-intracardiac repair for a tetralogy of Fallot. We can also use it for the aortic regurgitation, using the same formula. And another important thing which we can use to assess the severe aortic regurgitation is looking at the PC at the descending aorta. So if it on the descending aorta, if it shows holodiastolic retrograde flow, that signifies that aortic regurgitation is very severe. So that is one of the indirect evidence of quantifying the aortic regurgitation, just to look at the PC of the descending aorta, and if it shows, you can see that in this case there is only minimal flow reversal at early diastole, whereas in this case there is a continuous flow reversal during the entire diastole, which suggests that it is a severe AR. Coming to the aortic valve, coming to the mitral valve or the other tricuspid valve regurgitation, here we can't generally use the direct method of regurgitation. Here, how will you calculate is, either we can use the LV stroke volume minus RV stroke volume. Other method what we commonly use is, since it's very difficult to do a PC directly at the AV valve level and to quantify it, because the direction of the jet may be different, there we can get a multiple jets. So what we will quantify indirectly is, we will calculate the ejection fraction using the cine images. Then we calculate the amount of forward flow that is happening in the aorta using the PC. If you subtract the ejection fraction, the so-called the stroke volume, if you subtract the part of the aortic forward flow, then the remaining flow going to be MR, in the absence of any other interventricular septal defect. So this is that makes sense, isn't it? So what we will do is, we will do a volumetry for the stroke volume, and we will do a PC at the level of the aortic valve. We calculate what is the aortic valve forward flow, just to subtract the aortic flow from the LV stroke volume, which will give you the mitral regurgitant volume. So this is one of the, again, very easy method. Only thing is, we will be combining both the planimetry using cine sequences and the phase contrast flow study. So when you are doing a regurgitant fraction, as I told earlier, for PR and AR, it is very easy. We will be directly looking at only the valve level. Whereas when you are calculating the MR, we have to do both the cine sequences as well as the PC. And here the denominator is different. You have to use the denominator of LV stroke volume, not the anticreate volume, because you are not calculating the anticreate volume through the mitral valve. Can we calculate a combined, if there is a patient having both MR plus AR, can we quantify both how much it is happening, or can we quantify it separately when the patient has multivalvular disease? Can we quantify AR and the MR separately? Yes. MR, again, we can use the same formula. This, the aortic valve PC, when it shows the regurgitant volume, directly at the aortic valve level, it doesn't get affected by whether patient has a MR or a VSD. It directly shows how much amount of regurgitation happening at that level. So there is no problem in quantifying the AR even in the presence of a multivalvular disease. When you are coming to the MR, we are using the same formula, but only thing is if the patient has associated AR, then we have to subtract the aortic regurgitant volume when you are calculating the MR fraction in the denominator. We can also look at the combined aortic AR and the MR volume by subtracting the RV stroke volume and the LV stroke volume if there is no right-sided valvular disease. One more thing you have to remember is the value what you are using in an MR is not equal to the echo. The values what you are using in an MR is slightly different as compared to the echocardiography. Also, it's very useful technique when you are using the mitral annular disjunction arrhythmia syndrome. Yeah, it's playing. So here we can actually quantify the length of the mitral annular disjunction. Not only that, we can also quantify and we can assess the myocardial scar, which is the arrhythmogenic substance. Another added advantage of an MR is we can simultaneously do a phase contrast flow study at a multiple level. We can simultaneously assess both at the mitral valve, tricuspid valve. Also, we can look at what is happening in the aorta and the main pulmonary artery. So this is an example of a TOF status post ICR where we can see that there is a severe PR, that is okay. But we can also look at the time difference between the pulmonary valve closure versus the tricuspid valve opening. There is a significant delay due to the diastolic dysfunction. So we can get lot more physiological information which we may not be able to possible in an echo, where we can assess on echo only each valve separately, we cannot assess simultaneously. So this gives you the importance of multimodality imaging when you are looking at any myocardial pathology, especially valvular pathology, where cardiac MRI can be useful not only when looking at the assessing the severity, risk stratification, also we can use it for a pre-surgical planning. Moving on to the cardiac MRI in congenital heart disease. See what cardiac MRI offers in congenital heart disease. We have a lot of sequences. One is assessing the morphology by looking at the black blood sequences as well as by looking at the cine sequences. And I also show you some images which is almost mimicking, similar to a CT angiography where you can get a volume images. But the added advantage of an MR over a CT is it gives a functional information, including the SAT-axis cine tricks images, phase contrast flow study, what we are discussing so far. And importantly, it gives you a tissue characterization in the form of T1, T2 map, LGE scar. Also, very, very important thing is now there is lot of interest on doing a 3D printing. Okay, and we can use the MRI data for 3D, using MRI data, we can do a 3D printing models for complex congenital heart disease. So these type of pretty images, what usually we'll do it using a CT, we can do it on MR angiography also, showing a very critical coarctation, almost like an interrupted aortic arch. This is a case of a pulmonary atresia. We can assess the branch pulmonary arteries and the major aorta pulmonary collaterals similar to the CT angio. This is a case of a mixed TA PVC where the right side pulmonary veins are draining into the portal vein, whereas the left-sided pulmonary veins are draining via the vertical vein into the left innominate vein, and also we can demonstrate there is a tight stenosis. So this is a obstructive type of mixed TA PVC. And this is the image that I was talking about. See, this is a non-contrast MR angiography. Similar to the CT scan, we can cover the entire thorax in about 5 to 10 minutes. Only the scan time is a little longer. It is a ECG gated and the respiratory gated sequence where we can easily assess the partial anomalous pulmonary venous drainage of the right upper pulmonary vein going into the right superior vena cava. So using this volumetric data, we can assess most of the both intracardiac and extracardiac pathologies. This is an interesting case of single ventricle with the herniation of the heart into the abdomen. status post PDGS 10 years back, now failing PDGS with the multiple venous collaterals. So we can assess both the intracardiac anatomy as well as extracardiac anatomy using a comprehensive cardiac MRI methods. And simply looking at the relationship between the aorta and the main pulmonary artery, we can interpret what can be the intracardiac abnormalities. As we know that normally the aorta will be right and posterior to the pulmonary artery at the annulus level. Whereas in a situs inversus, it will retain the posterior position, but it will be on the left side. Whereas in the case of transposition of great arteries, we know that the aorta will be anterior. In a DTGA, it will be dextroposed right and anterior, whereas in LTGA, it will be left and anterior to the pulmonary artery. Whereas in the case of DORV, many times we see that it will be either side by side or anteroposteriorly located. So, by looking at the relationship between the aorta and the MPA, we can able to come to a reasonable conclusion of the intracardiac pathology. We can also look at the other intracardiac abnormality. This is a case of a tricuspid atresia. We can see that how beautifully MRI shows the abnormality of the tricuspid wall, and we can see that how blood flow is happening from the right atrium into the left ventricle, and we can quantify the single ventricles. If we want to quantify the volumes of the single ventricle, will be a little difficult by an echo because here a lot of assumptions are involved, whereas on MRI we can quantify both the RV and the LV very accurately. If the patient, suppose if you don't have a good technician to do a different cardiac views, where in a complex diseases, it can be, can have a dextrocardia, mesocardia, you can have different types of all situs anomalies. Just by doing a continuous cine sequences in all three planes, axial, coronal and sag, may be sufficient. You can get still lot of information. For example, this case of a post complete TGA, status post atrial redirection surgery, where you can see that the pulmonary venous conduit which is draining into the through the tricuspid valve into the right ventricle, as well as the systemic venous baffle, the SVC and the IVC. Also, we can do just a contiguous coronal and the sagittal sections. Again, we can nicely see both the SVC baffle and the IVC baffle going into the left ventricle, as well as the sagittal cine sequences showing the severe pulmonary stenosis. So, all this information can be easily assessed even without doing complex different views. So, all these anatomical information, maybe we can get it easily with an echo, especially if the echo window is good in an young people. But in a lot of people in India, they come at the age of say 10 years, 15 years, even 20 years after an initial surgery. If you want to assess them post sternotomy status, echo window may not be good. In those cases, then MRI will be very, very useful. And looking at the other functional information, what you can get it is by doing a MR angiography known as the TRIX MR angio, where you can get something similar to our DSA images, where within few seconds we can acquire the entire thoracic cavity, and we can run like a cine loop. So this is again a post-atrial redirection surgery, where you can see that contrast coming from the SVC going into the LV, then opacifying the pulmonary artery coming back into the pulmonary vein, then opacifying the RV and the aorta. So we can get the sequential opacification of the chambers and the cardiac structures, and we can assess where is the pathology. And for calculating the RV volume, currently the cardiac MRI is the gold standard, especially following a Fallow's tetralogy repair. We can quantify, and most importantly, we can use this for follow-up. So that is very important, because it has a very less inter-observer variability as well as intra-observer variability as compared to the other imaging modality. Now we can use it for a follow-up, so that we can quantify even a 10%, 15% increase in the RV volume, or 10-15% increase in the pulmonary regurgitated fraction can be more accurately assessed. Coming to the phase contrast flow study, one important method where we will use PC is for quantifying what is the QP and the QS in the case of left to right send. So, even in a simple cases like a ASD, VSD, if the patient is presenting late, and if you want to really quantify whether patient already developed a pulmonary vascular resistance, and if you want to quantify how much is the QP and the QS, We can do the cardiac MR easily. Of course, we have discussed about the pulmonary regurgitation volume and regurgitant fraction, especially for the PR that's happening in post intracardiac repair of TOF. We can also quantify the gradient across the coarctation of aorta or any valvular stenosis. This one case, I'll show you, and you can look at it, how useful is the cardiac MRI, where it's very difficult to get information from other imaging modality. This is the case of a tetralogy fellow with the pulmonary atresia, where both the lungs are supplied exclusively by the two MAPCAs. One MAPCA to the right side, which shows a tight stenosis, and the other MAPCA to the left lung doesn't show any stenosis. So by looking at this morphology, we think that, yeah, there is a pathology on the right side, there is a stenosis, and you will try to open that stenosis if the patient have any symptom. But when you look at the PC flow study, if you look at the blood flow to the right lung is more as compared to the blood flow to the left lung. Why? Because this right side MAPCA is protected by that stenosis, whereas the unprotected left side MAPCA, which produced the pulmonary hypertension, producing the Eisenmenger syndrome with reduction in the blood flow. Also, we can see that in the MR angio, there is a severe pulmonary hypertension which has happened on the left side as compared to the right lung, which is not Eisenmengerized, and that stenosis is protecting that, preventing it from developing a Eisenmenger syndrome. So by looking at the PC flow study, where we can directly quantify the blood flow, which will be very, very difficult by other imaging modality. So it gives lot of physiological information about the any particular pathology. Currently, there are newer imaging modalities available, not just the 2D PC, where you'll be looking at only the gray and white images. By doing the so-called the 4D flow imaging, once we acquire, which will take about 10 minutes or so, we can rotate it into any plane, and we can now look at the flow studies across any vessel. That will be possible, and it is going to come. It's already is available in some of the centers in India. So we can also now do the quantification of the myocardium scar, especially following Fallow's tetralogy, and this is what I was talking about. Currently, in our institute, most of the complex congenital heart disease, especially the DORV or a complex DGAs, are always we do the 3D printing. Either it can be a 3D printed models, and what we have currently now is the virtual 3D models, where we can just look at the through the spectacle, we can cut through the heart virtually, and we can look at into any plane. And most of the cases where the surgeons come to the lab, where they can visualize the all these pathologies virtually using these 3D models, and then the surgery become a little more easier. And where earlier, people thought that it is inoperable, and with the availability of these 3D printing models, the surgeons are more confident, and they can able to operate even the very complex heart diseases. And when we are looking at the any congenital heart disease, we will be looking at the 3 different segments, and we will approach any complex diseases using a sequential and segmental approach. Basically, heart can be divided into atrial segment, ventricular segment, and an arterial segment, with 2 connections, namely the atrioventricular connection and the ventricular arterial connection. Similar to any Rubik's cube, any type of combinations of mismatch is possible. So we have to go in a systematic manner. You have to look at the visceroatrial situs, atrioventricular connection, what is the ventricular loop, what is the ventricular arterial connection, what is the relationship of the great arteries, and other associated anomalies under the functional status. I'll just complete by showing one complex case where cardiac MRI gives you an overview of different morphology and the functional information. Now, this is a complex CHD came for cardiac MRI, which shows, we'll start with the abdominal situs solitus, where liver is on the right side, spleen on the left side, stomach on the left side, the IVC on the right side, aorta on the left side, suggesting visceral situs solitus. When you are coming to the cardiac side, the IVC and the SVC are draining into the right atrium, left atrium looks normal. Whereas when you are coming to the ventricular loop, it is an L loop, where the morphological right ventricle is on the left side as compared to the LV. We will identify morphological LV by looking at the smooth ventricular septum as compared to the moderator band and the septal muscle attachment, papillary muscle attachment on the septum on the RV side. So LV septum will be more smooth, suggesting that there is an atrioventricular discordance. Also, there is a ventriculo-arterial discordance where aorta arises from the RV, PA comes from the LV with the interventricular septal defect. It's not only giving the diagnosis, it also gives other information like the confluent branch pulmonary arteries, which is very, very important, sometimes difficult to see on echocardiography. The entire branch pulmonary arteries can be assessed and the pulmonary artery stenosis can be assessed. Here we can see that there is a tight PS. So most of these information now already available by echo, but what additional information MR gives is, it gives accurate measurements of the RV function in diastolic volume, in systolic volume, ejection fraction. It also do a quantification of the QP/QS. We can see that there is a severe reduction in the QP as compared to the QS. Not only that, for the surgeons, by looking at the LV to the aorta route, and we can see that any tricuspid valve or any conal tissue coming across the LV to aorta route, all those informations can be assessed comprehensively. And of course, we can use these MRI data for 3D printing models to plan a further surgery. So to sum up, in cardiac MRI gives both morphological information and functional information. Also, you can use it for tissue characterization, including the myocardial scarring. We can use it for 3D modeling. So those who are interested in further reading, I recommend this book edited by me as well as Dr. Sanjay and Dr. Vimal Raj, and CT and MRI in congenital heart disease. And I also request everyone to register for our upcoming Indian Association of Cardiac Imaging conference, that is at Goa, 14, 15 and 16th October. Thank you very much.
This is informative for people who want to learn these subjects. And I think congenital heart disease, valvular heart disease, the spectrum remains still wide in this large country. And I am not expert in this, but what I can realize in my training days or even when I was doing this echocardiography early in my career, the most difficult portion is to see the confluence and the outflow tract. And that's really mind-blowing. And really, you have given the physiology is also very important. And probably that case what you showed, that pulmonary hypertension because of MAPCAS is a pertinent issues, definitely. So I think this is very important, and probably you need to do restudy after intervention.
Yes.
So that is the problem of accessibility and the cost. But in your center, I think it is done in a systematic manner.
Yes, yeah.
Thank you.
What is the youngest child? I mean, youngest age group of children you subject to cardiac MR vis-a-vis cardiac CT for congenital heart disease?
Yeah, so at our center, anyway, we have done cardiac MRI even in infant period, less than 1 year. But generally, we prefer CT in a young child. Especially if your area of interest is only looking at the extra cardiac anomalies, pulmonary arterial abnormalities, or a pulmonary venous drainage, all those things, CT hardly take less than a minute, where you can quickly finish it up. But if there is if you want to know about the physiology of the abnormalities, then of course cardiac MRI. And in our center, the most of the cases are adult, more than 60-70% are adult. And most common indication is the follow-up of the tetralogy of Fallot following intracardiac repair to assess the pulmonary valve replacement, mainly to quantify the RV function under the pulmonary regurgitation. Also, it's a lot of cases of complex heart diseases after just a preliminary yearly, just after following a BDGS or just a PA band for a complex diseases, when they are coming for a definitive treatment, then cardiac MRI is very, very useful. So that's what most of our cases of complex diseases are.
And which are the cases of valvular heart disease where beyond echo, both transthoracic and transesophageal, would you advocate cardiac MR? I mean, in terms of additional information?
Yeah, so one is, for example, if you want to assess the myocardial pathology, for example, in the case of arrhythmogenic mitral annular disjunction, if you want to know is there any myocardial scar involving the papillary muscles, or for aortic stenosis, if you feel that if you want to postpone for some reason for 1 or 2 years surgery, then you can do a cardiac MRI and see whether patients start developing a myocardial pathology. That is one. Second is when there is a dissociation between your echo finding and your clinical finding. If you feel that patient is not that symptomatic but echo looks like more severe, or if the patient is symptomatic but echo doesn't show that severity, then in that cases you can use MRI as a problem solving modality.
Okay, now it's open for discussion. Yes, Devdatta.
Yes, absolutely. Can you hear me? Thank you for these magical pictures. Absolutely mind-blowing. And just wanted to ask you, sir, you showed a lovely case of aortic stenosis where there was a lot of subendocardial ischemia. So is there any particular timing, like the child may have congenital aortic stenosis, then can have a balloon valvuloplasty on follow-up. So would you recommend a particular timing where you would ask for a cardiac MRI in these children?
Yeah, generally I don't have much any experience on the congenital aortic stenosis, but most of the studies what they recommend is in the case of severe aortic stenosis, and if you want to say otherwise if you are not planning a intervention, if there is indication for intervention, then you can go ahead and do it. But if you think that patient still has severe aortic stenosis, but for some reason if you want to wait, and if you want to know whether we can wait for some more time, we can buy some more time, and if the patient starts developing a scar, then it's an indication for doing an early intervention.
Thank you, sir. Thank you.
Anyone else? Ishita, would you like to ask something? Anyone or?
Difficulty in our institute is mostly performing MRI, cardiac MRI in children, because they have the issue of getting the heart rates and proper images, which is not possible. So we go for most of the CT pulmonary angio, but when it is very complex cases, we can't perform this cardiac MRI. That is an issue. And we don't get such help from our radiologist friends for the MRI part.
Yeah, yes, the congenital disease, you need some expertise. One is, as compared to the CT, you don't need a heart rate control for an MR. Because whatever may be the heart rate, we can adjust the parameters and still we can get a good data. So, and even if the patient is not holding the breath, still we can do a free breathing sequence. Only thing is, patient should lie down inside the gantry without any movement. So, in case baby is not cooperative, we need a cardiac anesthesia. So, we have a very good cardiac anesthesia team. Where we don't have any major problem. They, even in case where we need a controlled ventilation, they will intubate, and when we ask them to hold the breath, they will just disconnect the ventilator. Then we will do the scanning of 10 seconds, 15 seconds scan. We'll quickly when it stop, then they will reconnect it. Then we'll continue the scan. So that is very important.
Thank you, sir.
Any more questions? So, thank you, Dr. Kannan. We'll call you back for the seat to talk on.
Can you ask the companies to have an open lead system, because in MR heart you don't need the brain to be inside. Okay, so if the lead can be open and the head can pop out, many of the problems will go away.
Yeah.
So you work with the companies closely. Can you suggest them something like that? Otherwise, cardiac MR will never take up that way.
Yeah, maybe in future those things may be possible. Anyway, currently the major problem with the open MRIs are they are low Tesla systems. So you need a supercount magnet like at least 1.5 Tesla to do a cardiac MRI.
Okay.
Thank you.